Good day, ladies and gentlemen. Welcome to this instruction course on angle closure and angle closure glaucoma, organized by the Asia Pacific Glaucoma Society, APGS. APGS is an association of eye doctors with a special interest in glaucoma. It was established in 2011 with a goal to facilitate contact between glaucoma specialists in the region, to encourage collaboration, and to provide opportunities for exchange of skills and knowledge. So in this course, we'll look at some important investigations for angle closure and angle closure glaucoma, as well as some important laser and surgical management options. I am Clement Tham from the Chinese University of Hong Kong. I'm also the Vice President of the Asia Pacific Glaucoma Society. Let me start with a very brief talk and overview of a management approach in this disease. These are my financial disclosures. Now, in primary angle closure glaucoma, first of all, we aim to open up all appositionally closed portions of the angle. If intraocular pressure is still uncontrolled, we consider starting topical medications. And if IOP is not controlled by maximally tolerated medications, then we proceed to further surgery. There are several means that allow us to open up appositionally closed portions of the angle, and these include laser peripheral iridotomy, argon laser peripheral iridoplasty, and also lens extraction. Now the word primary in PACD, primary angle closure disease, can potentially be misleading because usually this word implies that there's no known mechanism for the angle closure. But actually, several mechanisms are now known and have been documented for primary angle closure, and these include pupil block, plateau iris syndrome, lens-related mechanism, and also possibly choroidal pressures. Now this graph here tries to symbolizes the contributions of different mechanisms in causing angle closure in different eyes. You can see that the higher the column, the greater is the anatomical predisposition to angle closure. And in different eyes, the contribution of the various mechanisms vary. Say, for example, in eye number 3 here, the main mechanism leading to angle closure is plateau iris, while in eye number 4, the main mechanism leading to angle closure is the lens, with the lens thickness being more important than the lens position. Now, in this second, very similar graph, now this time this is the same eye but at different age. You can see that with increasing age, the contributions of these different mechanisms also vary with time. And with increasing age, the lens thickness plays an increasingly important role, and possibly also pupillary block may also increase its contribution with age as well as the lens thickness increases. So the objective of surgery is try to eliminate the main mechanisms leading to angle closure by selecting a procedure or a combination of procedures with the least amount of surgical risk. Now this graph here tries to summarizes the management approach in angle closure. Now I'm going to present to you two flow charts. The two flow charts represent two extreme hypothetical scenarios. In this first scenario, we are looking at an eye with 360 degrees complete appositional angle closure. In other words, if you can reverse the mechanism leading to angle closure, the trabecular meshwork may once again be exposed to aqueous drainage, and you may be able to control the intraocular pressure without further glaucoma interventions. Under this situation, if there is visually significant cataract, then we normally proceed to cataract extraction first. If there is still persistent appositional angle closure after cataract extraction, then plateau iris syndrome may possibly be the cause of the appositional closure, and we may then consider argon laser peripheral iridoplasty, ALPI. Whereas if there is no visually significant cataract, then we may consider performing laser peripheral iridotomy. And if there is still persistent appositional angle closure after iridotomy and there is ocular hypertension, then we would have to decide whether plateau iris configuration or the lens is the main mechanism. If it is PIS being the main mechanism, then we may consider ALPI. But if it is the lens being the main mechanism, then we may consider lens extraction. Very often, in the majority of eyes, both mechanisms may play a role, and then we would have to decide which is more important. And very often, lens or perhaps cataract extraction may be the first procedure of choice. Now, in the next hypothetical scenario, we have 360 degrees of synechial angle closure. Now, under these circumstances, what it means is that even if we do something to reverse the angle closure, the trabecular meshwork may still be blocked off by the peripheral anterior synechii and therefore may not be accessible to the aqueous for drainage. So in this situation, if there is visually significant cataract, then of course we may consider cataract extraction, but very often we may have to consider one other IOP lowering surgery, which can be in the form of goniosynechiolysis, endoscopic cyclophotocoagulation or transscleral cyclophotocoagulation, one of the minimally invasive glaucoma surgery, trabeculectomy, or glaucoma drainage device implantation. The choice of these procedures depends, of course, on surgeon's factors as well as patient factors, and we may have to take into consideration the severity of the glaucoma, how badly is the IOP controlled, how much IOP we need to reduce for that particular patient, and also how much drug reduction we need to consider. And all these factors have to be taken into consideration to decide which procedure may suit the patient best. If there's no visually significant cataract, then we have to decide whether the lens is the main mechanism. If the lens is the main mechanism, then we may consider clear lens extraction with or without another IOP lowering surgery. Whereas if the lens mechanism is significant, we may consider one of these IOP lowering surgery with or without clear lens extraction. So hopefully, these two flowcharts can give you an overview of a management approach for angle closure based on the angle closure mechanism, and the subsequent talks will go into much greater detail on some of these important procedures that help in the control of angle closure as well as in the control of IOP. So if you are interested in more contents on glaucoma, please do mark your diary 2021 in August. There will be the Asia Pacific Glaucoma Congress organized by the Asia Pacific Glaucoma Society. The Congress will very likely be in August, but the exact dates will very soon be published both on our website as well as online. Thank you very much once again for spending your time with us, and I very much look forward to meeting you in person in Kuala Lumpur in August 2021. Thank you once again.